Hello, I'm Emmanuel Trabucco, one of the urogynecologists at Mayo Clinic, Rochester. Today, I want to talk to you about hysterectomy, or the surgical removal of the uterus. In particular, I want to discuss three important issues you should consider when contemplating whether or not to remove your uterus. First, what should be done with your ovaries? Second, what are the potential implications regarding surgery and sexual function and intimacy? And finally, which route should be undertaken, robotic, vaginal, open, or laparoscopic? If you're watching this video, you likely have a condition, be it heavy, painful bleeding, fibroids, polyps, whatnot, that has not been adequately treated by non-surgical or uterine-preserving options. You're now ready to consider a hysterectomy and are wondering what should be done with your ovaries. Typically, ovarian removal has been recommended to decrease a woman's risk of developing a specific type of ovarian cancer called epithelial ovarian cancer. This cancer is relatively rare, happening about 1 in 70 times if you live to the age of 70. Unfortunately, there's no good screening test for ovarian cancer, and most women who develop this disease present with advanced cancer that's treated but not curable. As a result, many gynecologists recommend that the ovaries be removed when doing a hysterectomy, even in premenopausal women. The main problem with this rationale is that ovarian removal has been shown to cause much more harm than benefit. In fact, a study using statistical modeling showed that although ovarian removal in 10,000 women ages 50 to 55 led to 47 fewer cases of ovarian cancer, 158 more women died from complications of osteoporosis, and 858 more patients died from complications related to heart disease. In other words, the harm associated with removal of the ovaries far exceeded the benefit. Other studies have confirmed this finding, and a benefit to preserving the ovary is noted up to the age of 64. In summary, I would suggest that if you are a low-risk patient, in other words, you have no genetic predisposition or strong family history of cancer, that you preserve your ovaries at the time of hysterectomy. I would make that recommendation well after menopause into your mid-60s. We do, however, recommend that the fallopian tube be removed in all women undergoing hysterectomy, as 50 to 75% of the ovarian cancers we're trying to prevent actually start in the fallopian tubes. So lower your risk of this type of cancer by removing the tubes and preserve your ovaries. Let's now talk about a second important factor that you should consider, the impact of hysterectomy on sexual function. First, it is important to understand that female sexual dysfunction is very common and much more complex than erectile dysfunction in men. This topic is beyond the scope of this presentation, but suffices to say that pain is a common issue detected prior to undergoing hysterectomy. Hence, it is important to have a thorough history and physical exam to rule out other sources of sexual dysfunction. Assuming you have no issues with your sex life, what should you expect after surgery? Does hysterectomy impact desire or orgasm? What should be done with the cervix? As many of you listening may have already noticed, there are many anecdotal accounts in the internet of women having drastic negative changes in her sex life after hysterectomy. The question to ask, though, is what was done with her ovaries at the time of surgery? This is the most critical consideration, as premenopausal ovarian removal at the time of hysterectomy leads to immediate menopause. Unlike natural menopause that undergoes a transition that takes anywhere between 3 to 5 years, surgical menopause takes only 48 hours. The certain decrease in estrogen has drastic impact on libido, vaginal lubrication, and sexual desire. In other words, sexual dysfunction after hysterectomy has more to do with whether or not the ovaries were removed than with hysterectomy per se. The question of whether or not to remove the cervix has also been studied. 1 year after surgery, there was no difference in frequency of intercourse, sexual desire, frequency of initiating intimacy, or orgasm between women who had a complete uterine removal and women who had the cervix preserved. Interestingly, there was an increased frequency of intercourse in both groups compared to prior to hysterectomy. This data would suggest that hysterectomy has no negative impact on sexual function, regardless of whether or not the cervix is preserved. More importantly, hysterectomy, by eliminating the symptoms that tend to limit intimacy, such as heavy or irregular bleeding, leads to more frequent rather than less frequent intimacy after surgery. There is presently no data that preserving the cervix is beneficial. You should be aware, however, that there is a 10% risk of persistent cyclical bleeding, and there will be a need for continued pap smear surveillance if the cervix is preserved. In general, we recommend the cervix be removed at the time of hysterectomy. Lastly, as you contemplate a hysterectomy, it's important that you understand that there are several different ways to remove the uterus. Historically, the most common way to remove the uterus was to make an abdominal incision, a procedure called abdominal hysterectomy. Given the invasive nature of the procedure, patients spent days in the hospital and had a prolonged recovery. New, minimally invasive options have been developed that uses smaller abdominal incisions and a camera to remove the uterus. When this procedure uses robotic assistance, it's called a robotic hysterectomy, and if no robot is used, it's called a laparoscopic hysterectomy. Both of these procedures have smaller incisions and shorter recovery compared to the abdominal approach. Cosmetic outcomes are overall good. Nevertheless, it requires abdominal incisions, typically 4 to 5 for the robot and 3 to 5 for the laparoscopic approach. These procedures are associated with increased cost and complications, increased risk of breakdown of the vaginal incision, and takes longer to perform in general compared to vaginal hysterectomy. At Mayo Clinic, we have pelvic surgeons that are able to remove the uterus through the vaginal canal, avoiding all abdominal incisions, a procedure called vaginal hysterectomy. Even though the American College of Obstetrics and Gynecology recommends that hysterectomy for non-cancer indication be performed by the vaginal route because it takes less time to perform, it is safer, patients recover faster, and it costs less, the number of vaginal hysterectomies performed in the United States continues to decline. In fact, many patients I have seen for a second opinion was only offered a robotic or laparoscopic approach with no discussion of alternatives. This trend in increased use of robotic surgery is due to perceived contraindications to vaginal approaches, including the need for removal of the fallopian tubes or ovaries, history of prior cesarean section, having had no prior children, and having a large uterus due to benign growths called fibroids. Another factor is that fewer hysterectomies are performed annually in the country, leading gynecologic surgeons to become ever more specialized, being able to perform primarily one type of procedure. Nevertheless, numerous research studies and our surgical experience have shown that over 90% of women with one of these perceived contraindications can safely have the uterus, the tubes or ovaries, if desired, removed by the vaginal approach. Moreover, we have the surgical expertise to provide the entire spectrum of hysterectomy approaches should your specific case not be conducive to the vaginal route. Thank you for your attention today, and hopefully you found this information useful. You can follow us on Twitter at Mayo Gynecology or get more information in our site, mayoclinic.org, for more information on hysterectomy and related procedures. Thanks again for your attention.